Well, hello everybody. Welcome to It's Almost Finals Time. Today we're going to learn about DKA, also known as that one thing that type 1 diabetics can get, diabetic ketoacidosis. Pathology's in the name. You might be thinking, Jessica, what's wrong with your hair? I'll tell you what's wrong with my hair. I have depression. So let's talk a bit more about diabetic ketoacidosis, DKA. You're most commonly going to see it in type 1 diabetics. My mouth is dry, excuse me. Did I mention diabetes? Anyways, you're most commonly going to see this in type 1 diabetics, although it can happen in type 2. But for the purposes of this course, which I'm not in charge of in any way, shape, or form, I'm just trying to survive it, it's going to be type 1 for the test questions. With type 1 diabetes, there's no insulin. Your body's not making the insulin on its own. Normally, insulin carries that blood sugar that's in the blood into the cells. Your cells need the sugar for basically everything. It's their energy. Yes, I know the mitochondria is powerhouse of the cell, but they got to do their pre-workout stuff too. It's called sugar. Anyways, so if the sugar is not going into the cells, where is it? It's in the blood, which is why you're going to see it ranging from 250 to 800. That ain't good. Do you want your sugar to be that high? I don't think so. I really don't think you want to. So what does the body do if there's no sugar? I'll tell you what it does. The liver goes into what it does. Sorry, got distracted because the candle burned out completely and it smelled like something was on fire because the candle was on fire, but it was also not on fire anymore. If there's no sugar going into the cells, the body's like, holy shit, we need some energy. What are we going to do? And the liver says, I have an idea. Let me break down some fats. It's called, what's it called? Lipolysis. The liberal agenda. Basically, fats are broken down into fatty acids and glycerol. Glycerol normally can be, made into glucose. The fatty acids, they break down into ketone bodies. And those, they're going to show up in your pee. Ketoacidosis. Keto. Anyway, we're going to have metabolic acidosis because this whole process, unfortunately, it's going to cause the pH to go down and the bicarb is going to go down. It's also why you're going to see what is called hyperventilation or Kussmaul respirations, deep labored respirations. Your body is trying to regulate that pH, but all it really does is smell like fruit. So what other clinical manifestations are we going to see with DKA? We're going to see polydipsia, fatigue and weakness, headache, nausea, vomiting, acetone, fruity breath, hyperventilation, mental status changes. So what does this look like laboratory-wise? Well, I've already mentioned the urine ketones. I've already mentioned the metabolic acidosis, which is the low pH, low bicarb. We're also going to see decreased potassium. That ain't good. You need potassium. I already mentioned blood sugar going to be real high. You may not necessarily see a decrease in sodium. You might, but you're definitely just going to see a change in sodium levels. But you will have a normal serum osmolarity. That'll come into play when we talk about HHS later on. And also, you're going to see a high BUN creat level. Now, why are we seeing changes in the potassium and the sodium? Well, because the kidneys are trying very hard to excrete that excess glucose. And when they're doing that, they're also excreting potassium and water. Basically water and electrolytes. So potassium's going to go down, sodium might go down, but basically you're just going to see a change in what the baseline was from then to now. You're going to see some sort of a change. And that's why. The body's trying to compensate, and sometimes when the body tries to compensate, it creates more problems. much like me when I'm trying to fix my problems in life. Sometimes I just make worse choices. So, what the hell are we gonna do about this? Well, we've got 3 priority treatment components. Number 1, we want to correct the hyperglycemia and the metabolic acidosis. Let's talk about how we do that. Don't think too hard. You need insulin. IV, regular insulin, like in an IV pump, because you're not trying to kill your patient. You need that. If you can fix the hyperglycemia, you can fix the metabolic acidosis in this case. Give that insulin. Now, we had another core issue going on, which was excretion of fluid and electrolytes, as the body's trying to excrete all this extra glucose that's in the blood. Sometimes I wonder why I'm even here. Does anyone care I'm trying to study for finals? No one cares. So we're going to start off giving normal saline, about a half liter to a liter, and then when we get the blood sugar down to about 250, because we don't want the patient to become hypoglycemic, we're going to do half normal saline and half D5W. That's dextrose, sugar. I know, it sounds weird, but think about it. Do you want your patient to die? The answer is no. It's too much paperwork. This might be about the time you're tempted to say, I have a nurse extern. She's somewhat intelligent. Let's make her do every single hourly blood sugar check. Wrong-o. No. Does she have 11 other patients? Yes, she does. Is that fair? No, it's not. Are you in charge of titrating the insulin drip? Yes, you are. Is the nurse extern a nurse? No, she's not. Do not put this on her. She's willing to help out, but that ain't her job, and you know it. You know it. Search your heart. You know it. All right. What was the other thing we talked about? Give you a hint. It goes along with the electrolytes. We need to replace the potassium. We're losing a lot of potassium. It's coming out. It's coming out in the urine, the kidneys. That ain't good. We need potassium for basically a lot of stuff. I don't know. I'm not a physiologist or a psychologist or a physician. What I do know is we want to replace the potassium. I learned in clinical, actually, that oral potassium tends to be more effective because it needs to be absorbed. But anyways, you can do it IV, I guess. So if we're replacing the potassium, we need to make sure we're monitoring EKG because potassium can affect your heart rhythm and rate. We want to be doing labs. Just be safe and do everything, but think about it. We already talked about that we had changes in electrolytes. We already talked about metabolic acidosis. We already talked about blood sugar. We already talked about these being elevated. Do the labs. See if your patient's getting better. It's your job. And we need to be monitoring the eyes and nose. There is a risk of fluid overload. Okay, I believe that says overload. So we don't want that. Your patient's got enough going on. Listen to the lungs. You're going to hear crackles if there's overload. Check for edema. Measure that output. You can do it.